now in day 2 of this program and hope you all are extracting maximum out of it. We'll start with the first session. Now I would like to request Ms. Jidnasa ma'am to introduce our guest speaker, Dr. Sooraj Ratnakumar sir. Over to you, ma'am.
Thank you, Anagha. Good morning.
Good morning.
Yes, good morning.
Uh, it is my immense pleasure to introduce today's eminent speaker, Dr. Sooraj Ratnakumar sir. Sir has completed PhD in biotechnology from the University of Cambridge. Also, sir has gained 3 postdoctoral research fellowships in the University of Washington, Seattle, EPFL, Switzerland, and the University of Cambridge, UK. His area of expertise includes molecular biology, especially gene regulation and cell signaling. Sir has founded a pioneering personalized medicine and molecular diagnostics lab, Swagin. At Swagin, Sir leads discovery and invention in developing rapid, easy, and affordable tests and kits for personalized medicine in various medical specialties, including oncology, as well as in wellness genetics such as sports fitness, diet nutrition, etc. Through these innovations, Sir has championed Swagin, winning several awards from governments such as DST, DBT, industry bodies like CII, FICCI, and institutions like IIT Kharagpur, IIM Ahmedabad, and BITS Pilani. Sir is a member of expert committees and panels in personalized medicine, oncology, and infertility. With this brief introduction, I request you, sir, to begin with the session. Over to you, sir. Thank you.
Thank you very much for the introduction. And I'd like to thank Dr. Suhit and Dr. Firoj for the kind invitation to present to your faculty. Shall I start the presentation?
Yes, sir.
Um, is that working? Can you all see the slide?
Yes,
Yes,
sir.
it is.
Okay, great. So I'm going to be talking about precision diet and nutrition using genetics and their applications both in daily life for healthy people as well as people with various conditions or diseases. So we're going to be looking at, we'll start with personalized medicine or precision medicine because that's where it kind of all originates. And we will have a brief introduction into that. We will understand the genetics and molecular biology behind personalized medicine or precision medicine, and then lead that into effects. And in these, we will be looking at nutrition, nutrition leading to, or bad nutrition leading to diseases, and the impact of genes in leading to diseases because of nutrition, the importance of nutrition in pregnancy and children with certain genetic variations, the importance of nutrition and genes contributing together to cardiovascular and cerebrovascular disease, genes contributing to nutritional deficiencies, but we will not be looking at genetic mutations leading to, the deficiency diseases such as scurvy and all that. That's not the point of this presentation. The point of this presentation is more to look at how genes affect the majority of the population, or how genes affect the ordinary population who are not, diagnosed with congenital illnesses. And then finally, we will also be looking at other aspects of wellness genetics. For instance, how nutrition can play a role in skin and hair wellness, in fitness, sports, persons, areas like that. So when we look at medicine, medicine first started with trial and error medicine, that, okay, one prescription fits all. and therefore the same drug, anyone walking in with a certain condition will be given absolutely the same medicine with the same dosage and all that. Later on, we entered the era of empirical medicine, where they started doing a more laboratory tests and investigations, and then arrived at a more definitive diagnosis, narrowing down the prescriptions. But even this was not enough. This was still a case of when shooting in the dark, it is a good idea to use a machine gun. For example, when you take a case of anyone with a heart disease or hypertension, high blood pressure, you'll generally see that they are taking about half a dozen different medications to control uh, their heart condition and blood pressure. And among these various medicines, some of them may be working well for them, some of them may have absolutely no effect, and some of them may be doing more harm than good to their body. So this is where we enter the era of precision medicine or personalized medicine. It is less than about 20 years old now. And why this personalized medicine or precision medicine? We have this common idea that pharmaceutical drugs will lead from ill health to health. But is that true? So there are various conditions where we see that a single class of drugs do not have any effect on a huge segment of the population. So if we take cases like depression, asthma, diabetes, about 40% of the population of the patients will not respond to a single class of drugs. And this only increases in other diseases like Alzheimer's. And in cases like cancer, 3 out of 4 patients will not respond to a certain class of drugs. That is a very high proportion. So why is this? This is mainly because genetics plays a huge impact and role in how the drugs are metabolized and how they behave within the body, both in terms of safety as well as toxicity, efficacy as well as toxicity. So this number has now increased. There must be more than 300 different drugs which have US FDA mandated drug labels that must contain pharmacogenetic information. So pharmacogenetics is the field where you link genetics to the pharmaceutical products. So how the pharmaceutical products are affected by genes and variations within the genes. So now getting a little bit more deeper into the genetics and molecular biology, this background is going to be kind of important in order to understand the entire field of nutrigenetics and nutrigenomics. Every cell in our body has the nucleus, and within the nucleus, there are tightly packed chromosomes. Now, these chromosomes altogether contain 3 billion different bases. So every cell in our body has 3 billion bases. What these bases mean are basically the A, T, G, and C that code for DNA. So with 3 billion bases, a lot can go wrong. But we have a lot of proofreading and proof checking mechanisms in the DNA replication and transcription processes. So which means that the variations are kind of limited. But some of the variations sustain, and these are passed down along generations. Now, these variations, we generally call them as SNP, which stand for single nucleotide polymorphism, or shortly, we call them as SNP. Now, we can also refer to these as polymorphism or variant. I will be using these terms interchangeably in this presentation. So everyone is aware of genetic mutation. So what is the difference between genetic mutation and a genetic polymorphism or variant? For in all technical purposes, polymorphism or variant in the gene is also a mutation. But we will make this distinction so that it's easier for everyday understanding and use. So generally, when we say a genetic mutation, its frequency in the population is very rare, and it leads to a clinically manifested disease. So which means from seeing the person, the patient, doctor will be able to diagnose clinically that there is some disease condition in the patient. Of course, this can be tested genetically. This is usually absent in healthy controls. And examples of these are various congenital conditions. Whereas in the case of a polymorphism or variant, these are usually widely prevalent in the population, which means that people don't manifest these as disease conditions per se. So these are highly subclinical, and therefore these cannot be diagnosed in a clinic. And but the genetic variations are the underlying genetic variations are very much present, which means they can be tested and identified by genetic or molecular diagnostics. And these are also present in healthy controls. So people with a genetic variation need not necessarily result in um, a disease condition or even a sub-disease condition. So these are also present in healthy controls, and these can also lead to disease. And these polymorphisms or variants are present in almost every gene in our body. So generally, we see that all of us share exactly the same DNA, which means all of us share 99.9% identical DNA, all human beings on the planet. And the differences lies only in 0.1% of the DNA. But when we talk about 3 billion bases, 0.1% means there are differences in 3 million bases. And these are the differences that these 3 million base differences is what leads to all the genetic diversity, including what we are going to see in terms of particularly focused on nutrition today. So the idea of personalized medicine or precision medicine is to look at these 0.1% difference in DNA, and so take a population or take a particular individual, test for the particular genetic variations that they have, and then put them, categorize them into low efficacy or high efficacy for a particular pharmaceutical compound or medicine, and also in terms of low risk or high risk for severe adverse events for a particular class of pharmaceutical compounds. And based on these, the patient will be given more targeted therapy that will work for them with higher efficacy, but at much lower risk for side effects. This is generally personalized medicine or precision medicine. Now, that's all we are going to see about personalized medicine or precision medicine today. We will be moving mostly into nutrigenetics and nutrigenomics. And here we will be covering a wide variety of topics. We are going to be looking at nutrition and disease and the genetic causes of disease in nutrition. Again, mostly these are um, subclinical or widely prevalent in the population. And then we'll be looking at the importance of nutrition in pregnancy, in pregnant women and children, in terms of the genetic variations. And as I already said, in several areas of wellness and their practical use and daily applications as well. So starting with nutrition, their effects on disease, and the impact of genes in combining nutrition and disease. So the most common disease that we see is cardiovascular and cerebrovascular disease, and these can be combined into metabolic syndrome, where we talk about high cholesterol, hypertension, heart disease, stroke, all of these put together. And we all know today that this is more of a lifestyle-based disease condition or syndrome, and a huge part of the lifestyle is comprised with dietary intake. So here we'll be looking at some uh, uh, certain cases like high cholesterol levels, high lipid levels, um, uh, and a particular case of statins, and in this case, personalized medicine with statins, high blood pressure. Why we generally say, okay, when you have high blood pressure, reduce your salt intake. And then we'll also be looking at diabetes and diabesity, which also constitute part of the metabolic syndrome. So in terms of predisposition genetics, so this is one of the most common questions that we receive. We receive inquiries generally about, um, my father has diabetes, and I want to get a genetic test for to find out if I have a high find out if I have a high risk of getting diabetes. And we generally tell them that, okay, look, the science is not that advanced that you can do a generalized test and give you a particular score for a high risk of diabetes. It is going to be usually quite meaningless. And especially if you have family history of diabetes, then you can generally assume that you are already at high risk for getting diabetes by virtue of your genes. So a genetic test in this case is going to be there are cases in diabetes where genetic tests have a huge importance. So one of the conditions is called monogenic obesity or monogenic diabetes, where a single gene and variations in a single gene can contribute to development of obesity and diabetes in the individual. Now, another case that I can tell you is in terms of MODY. MODY is maturity onset diabetes in the young. And these have very well characterized genes and genetic mutations. And based on the genetic mutations, their treatment is also quite highly targeted. So genetic testing is very important in this case. Also, in case of type 1 diabetes, which is more of a very well-defined genetic condition, but we will also be looking at type 2 diabetes, mostly monogenic diabetes of type 2 form, and diabetic complications. Why do some people progress to diabetic complications faster, and why some people take much longer in their progress? So, starting with obesity, now we are going to be getting into genes and conditions uh, uh, in each particular condition. So let's start with obesity and how obesity is controlled also by genes, not genes that directly lead to, hormone disorders like thyroid, but genes that lead to hormone disorders of, less important hormones, such as the hunger hormone and the satiety hormone. Now, the first gene that we will be looking at is called FTO. And FTO is a gene that is in charge of regulating hunger. So, ghrelin is the hormone that is released by the stomach when we have hunger. And that hormone travels to the brain and informs us that, okay, you are hungry, so go find food. Now, people with variations in FTO find it they are very easily susceptible. They are very easily regulated by the hunger hormone, which means they're usually always turned on, and their impulse control is poor. So they have very easy temptation to food cues, and they usually tend to eat a lot more frequently, and they eat higher fatty foods. So these are generally the conditions of a person with a particular variation in the gene FTO. Now, conversely, on the other side, there is another gene called MC4R, which also operates on the brain. FTO operates in the reward response region, and MC4R operates more contrary to that. So, when we are eating and the stomach feels full, there is another hormone that is released called leptin, and this is generally called the satiety hormone. So in case of when we are eating, and normal response is that once our stomach is kind of half full, we start releasing leptin, and this goes to the brain and informs MC4R that, okay, you have eaten enough, so you can stop now. MC4R respond quite poorly to this. So which means they are not very responsive to satiety. They don't feel full easily, which means they eat a lot more. So excessive eating, and their appetite doesn't get reduced fast enough. So it takes much longer for them to reduce their appetite. So people with these, they can have a lot of lifestyle interventions, for instance, regulating their exposure to food cues, avoiding food courts when you visit malls, and be aware generally that, okay, this is generally just a food cue, and it's not the body telling you to eat, it's more like just the brain playing on your um, playing on you. In terms of lifestyle, for instance, of course, diet and exercise play a major effect, but also in terms of how to what to eat majorly in your diet. So people with FTO variations will usually be advised to increase their protein intake and reduce their fat intake. Similar things. On the other hand, the interventions are always going to be difficult to maintain for people with these variations, and interventions usually yield short-term results, and therefore long-term weight maintenance can be difficult, and they can also undergo bariatric procedures. Now, people with variations in MC4R, they have been shown to respond very well to a class of drugs, an example of which is liraglutide. There are now other drugs that are that have been approved in this category, such as semaglutide. So they respond where people with this variation especially respond very well. Now, I'll talk about a particular case that we recently got. It was a patient with type 1 diabetes, a 54-year-old female. She had been diagnosed long back, and then she faced kidney failure, and she was put on peritoneal dialysis. She got a kidney transplant, but the transplant was rejected, and therefore they had to restart dialysis. And then she had to move on to hemodialysis. And on top of all these, uh, eh, even if you don't consider all these effects, she still faced extreme weight loss. So she lost more than 20 kilograms, and the quality of life was very poor. Even while eating, she used to face profuse sweating and all that. So we'll look at a couple of genes, and then we will come back to this patient and what we found and how her life slightly improved and all that. So now moving on to diabetes from obesity. So diabetes is a very common disease. However, when you see how diabetes progresses, some people progress very rapidly from pre-diabetes to diabetes, and then they progress also fastly from diabetes to diabetic complications. Now, diabetic complications, there are several complications like diabetic nephropathy, diabetic retinopathy, neuropathy, and several other microvasculopathies. Um, Whereas others, they take much longer to progress from pre-diabetes to diabetes, and some of them will not face any diabetic complications throughout their life. So why do people behave differently, and why do some progress faster than others? Now, there are genes involved. Of course, lifestyle, diet, and exercise also play a huge impact. So never forget the importance of diet and exercise. But today we'll be focusing more on the genetic factors. Now, we'll be looking here at two genes. ACE is the gene that I think you will be all aware of this gene because it is angiotensin converting enzyme. And the class of antihypertensives called ACE inhibitors particularly acts on this gene and inhibits this gene. So ACE is a gene where when there is a variation in this gene, the gene acts the gene is regulated very differently. Now, just one second. Yeah. So the activity of the gene by virtue of the genetic variation itself will be decreased, whereas there is another, the complementary variation in the gene leads to increased activity. Now, people with a variation with increased activity, they respond much better to ACE inhibitors naturally. Now, when there is already a genetic variation that decreases the activity of the gene and therefore the protein, um, ACE inhibitors are going to be just redundant in these people. So you all know how ACE contributes in the RAS angiotensin pathway, and therefore it leads to several microvascular complications because it leads to the dilation and constriction of blood vessels, and therefore increased progression and faster progression to diabetic complications. Now, it's not just in terms of progression to diabetes and diabetic complications, but also higher risk of gestational diabetes, higher risk of hypertension in diabetes, ACE especially. Gestational hypertension is also an important factor with people with variations in the ACE gene. Now, the other gene that we'll be looking at is called RAGE. Now, a lot of the glucose that we eat, when there is excess glucose that is floating around, this glucose enters a pathway and it forms what are called AGE. AGE stands for Advanced Glycation End Products. Now, these advanced glycation end products, as the name indicates, they are mostly end products. They cannot be metabolized any further. So, which means that these tend to get accumulated. Now, these advanced glycation end products usually bind to the protein called, which is encoded by the gene called RAGE, or its AGE, or AGER is advanced glycation end products receptor, or RAGE is the receptor for advanced glycation end products. So they bind to this receptor which is present on the cells, they get internalized into the cells, and they get it accumulates in the cells. Now, the accumulation of advanced glycation end products within cells, it can lead to inflammation. And inflammation, as you know, is the basic cause for various microvasculopathies that you'll see in diabetes. Diabetes is a condition itself, and diabetic complications arise from chronic inflammation. So the accumulation of advanced glycation end products leads to vascular injury, delayed bone healing, microvascular dermatoses. We will also be seeing this in case of skin health and all that. And this has been shown very clearly that, about progression to diabetic nephropathy, retinopathy, and other conditions. Now, here so far, I'm not aware of any particular drug, pharmaceutical drug, that acts on this gene and therefore helps people with the genetic variant. There may be natural compounds that act on this pathway that needs to be explored. But generally, so as in case of diabetes, reduced glucose intake, antioxidants will play a better role because inflammation is generally it's an oxidative stress response. Now, coming back to the patient with diabetes type 1, um, so we advise that, okay, the patient has diabetes type 1, which means that the patient should be automatically tested for celiac disease. All people with diabetes type 1 must be tested for celiac disease. This is also according to the guidelines by various professional organizations. This is because the genes that contribute to type 1 diabetes and the genes that contribute to celiac disease are quite tightly linked. And so they travel together. So a person with type 1 diabetes also has high risk for the other. We found that this patient did indeed have very high risk for celiac disease. That is very likely why she faced extreme weight loss, sweating while eating, and all this. Celiac disease, in other words, is gluten sensitivity. We will come back to look at that in a little more detail. And therefore, we advise certain dietary changes. And this patient also had the variant, which leads to increased activity of the ACE enzyme. And therefore, ACE inhibitors will likely have a better effect on the patient. So based on these advice, the patient did improve in terms of diet, her experience during eating, weight gain, and all. But unfortunately, she did die of infection a few years back. Now, we looked at genes for obesity. And these are genes that, so obesity and diabetes are very complex conditions. These are usually caused by an interplay of several different genes contributing with lifestyle and diet and all these other factors. But there are cases where what we call as monogenic obesity and monogenic diabetes. Now, these are cases, as the name indicates, a single gene contributes to the development of obesity. And usually in these cases of diabetes, it's a diabetes rising more from the obesity. So overweight or obesity leading to diabetes. We have seen, so these are cases of type 2 diabetes, and we have seen the two genes in relation to obesity, the same genes, FTO and MC4R. So we will not be going back. So we've already covered this topic. Now, fat accumulation, so dwelling more in obesity and diabetes, fat accumulation and lipolysis. There is another gene called ADRB2, um, which regulates both adiposity as well as adipolysis. So accumulation as well as breakdown of fat. And people with a variation in this gene, they tend to have higher risk of accumulation of fat and reduced lipolysis, so reduced breakdown of fat. Their diet strategy will be for as general for obese people, but their exercise strategy have to be quite targeted because they find it where the bodies of these patients generally do not break down fat easily. So they need to enter an area of VO2 max, which increases their tendency to burn fat with vigorous, very vigorous physical exercise. Now, another commonly heard condition that you see is gallstones. A lot of people have gallstones and undergo nowadays laparoscopic surgery to remove their entire gallbladder. Now, this is called hyperbilirubinemia, that is high bilirubin levels, and gallstones is called cholelithiasis. So there are genes that predispose a person leading to these conditions. And here we will be looking at two genes again that contribute to this. So one is SLCO1B1, which transports bilirubin. So this transports bilirubin usually from the cells into, from the bloodstream into the cells, or from the intestine into the cells to be utilized and broken down. And there is another gene called UGT1A1, and this is the gene that enables breakdown of bilirubin. Now, a particular mutation in UGT1A1, and this is quite common among people. I mean, common enough among people. It's not very rare. And when there are two copies, so always, as you know, there are two copies of every chromosome. So that's why it's 46XY or 46XX, means there are 23 pairs of chromosomes. And this means that every gene, there are two copies of every gene. So in case of UGT1A1, when a person has two variant copies, that as in both the gene copies have variants, then we say that this person has Gilbert syndrome. So they accumulate high bilirubin levels, and later on in life, at any stage in life, based on their diet and lifestyle, um, they will display conditions of jaundice and liver failure. So in terms of, so variations in SLCO1B1 and UGT1A1 can predispose a person to gallstones, which will lead to gallbladder removal. And people with high bilirubin levels, they also, it is very important in terms of hemoglobinopathies, for instance, sickle cell anemia, beta thalassemia, alpha thalassemia. So the thalassemia patients, in these patients, these variants are very important because the variants aggravate the condition. Um, the the age of onset in these patients will be much earlier, and the frequency of disease, the pain, and all of those will be much higher. So there are several contraindications based on these genetic variations. Several drugs must not be given, or their dosage or the class of drugs itself must be changed for these patients. Now, moving on to the next condition, osteoporosis. Osteoporosis is, we generally hear about this in women. It can also occur in men, and usually in postmenopausal women because of hormone variations. So osteoporosis is generally porous bones, brittle bones. So the bone mineral density is low, and it leads to very high risk of fracture. There are at least 4 or 5 very important genes that predispose a person to osteoporosis. And some of these genes have quite easy methods to circumvent osteoporosis, and therefore to, if not to regain the bone mineral density, at least to maintain it and not let it deteriorate any further. So two of these, MTHFR and COL1A1, and also in case of celiac disease predisposes one to osteoporosis and fractures. So we will be looking at MTHFR in more detail later on today. Now let's look at celiac disease in a little more detail. Celiac disease, contrary to what we think generally, it is quite prevalent among South Asians and people of Middle Eastern descent. There are very well-defined mutations, which means that a genetic test is a diagnostic test. So people with the variations, we can confirm that they do have celiac disease. Celiac disease, in other words, is called gluten sensitivity. So which means they are sensitive to gluten. The body starts attacking. So the instead of attacking just gluten in the diet, the body starts attacking intestinal cells. And therefore, this leads to anything ranging from pain to diarrhea to inflammation, anemia, or it can, in some people, it may not lead to all of these. They may generally just complain about fatigue and tiredness and uh, uh, yeah, symptoms such as those. So iron deficiency anemia, because these patients also generally face malabsorption because their intestines are degraded. They do not absorb all the nutrients efficiently. So which means iron is not absorbed from diet effectively, leading to anemia. These, as you all know, most of the genetic conditions and the genetic variations are transmitted hereditarily. A lot of the milder variations which do not predispose to disease, they need not be tested in everyone. But people with celiac disease, it is generally recommended that anyone with high risk, they should get all their blood relatives tested to find out what their condition is. Generally, because it leads to poorer quality of life. Diagnosis is not very easy. It's not very straightforward because of generally the variety of symptoms, multiple different symptoms, and therefore diagnosis is not very straightforward clinically. So these people need, in terms of nutrition, supplementation in the diet, especially in terms of iron, folic acid, and they should avoid all forms of gluten. Avoiding all forms of gluten can absolutely restore full health back to them, and their intestines will recover. So, which means this can be easily treated, but avoiding all forms of gluten from diet is not very easy, um, especially here where not everything is available in gluten-free variations. Irritable bowel syndrome is not uncommon. Again, it can be common. There are a variety of causes. There are genetic causes, there are non-genetic causes. In this particular case, we are going to be looking at the gene MCM6, also called LCT. So irritable bowel syndrome usually means it can be a variety of diarrhea, constipation, the combination of both, uh, pain, discomfort, bloating, flatulence. Again, all several of these symptoms overlap with celiac disease. So MCM6 means they are sensitive to um, milk and dairy products. So this is called either lactose tolerance. I think we will be looking at lactose tolerance soon. So let's look at that. So lactose tolerance or intolerance. Shockingly, the majority of people will be lactose intolerant because all of us, being mammals, we have evolved so that when we are born as infants, we consume milk. Now, after infanthood, none of the mammals consume milk. You do not see this in any other animal species except human beings. So what happens is during infancy, there is a particular gene called MCM6, which is turned on, and therefore it digests lactose. It digests lactose, it absorbs the nutrients from lactose, which is, of course, present in breast milk. And once you cross toddlerhood and once you cross childhood, from early childhood itself, this gene is turned off in vast majority of the population in all mammals. So which means usually you do not digest lactose. Lactose is the predominant sugar in milk and dairy products, and you do not digest this. So this leads to the condition called lactose intolerance or hypolactasia, also called lactase non-persistent. So lactase is the enzyme that is produced by MCM6. Lactase digests the sugar lactose, and what lactase non-persistence means that in infancy there is lactase, but it does not persist beyond infancy, beyond childhood. Certain populations, because we have been consuming milk and dairy products for many, many thousands of years as a human population, certain populations and certain small segments of the population have developed a variation in this gene. And this variation evolutionarily leads to lactase persistence, which means the gene does not get turned off. It is produced even during adulthood, and therefore it digests lactose. And these people can consume higher levels of milk and dairy. So generally, for people with hyperlactasia, you would advise that nutritionally they should consume either zero milk or dairy products or absolutely minimal milk and dairy products. This will lead to general improvement in quality of life. And as we saw, if irritable bowel syndrome has a variety of causes, if the cause is because of lactase non-persistence, then avoiding milk and dairy products can also treat this condition. Now, the dreaded disease called cancer. So, there are cancers that are linked to nutrition. Now, we are not going to be looking at carcinogenic substances. It's not generally carcinogens that we are looking at here. We are looking more at cancers because of non-carcinogenic materials or general pollutants that absolutely all of us consume in today's world. Here, our focus is going to be mainly on GI cancers or gastrointestinal cancers. Gastrointestinal cancers comprise anything from gastric, esophageal, colorectal, rectal cancers. Now, we already saw this gene UGT1A1, um, and we saw that UGT1A1 is a gene that is important in breakdown of bilirubin. Now, not just bilirubin, we will be seeing also in a future slide today about how this is also important in toxin elimination from from pollution, from our diet, and all of these. And this is important in order to avoid the GI cancers. So persons with the variations, we will see how to alter their diet in the future slide. Celiac disease, also because of various different reasons related to the symptoms and intestinal degradation, also predisposes one to colorectal cancer. So we have seen a variety of diseases and conditions where nutrition plays an important role and how genes have an impact. Now let us look at pregnancy and very early childhood, and how nutrition and genes play a role. So as I said, MTHFR. MTHFR is a gene that is quite important during pregnancy. Almost every pregnant woman is today given folic acid as a supplement. And it is not absolutely necessary for every woman who is going to have a healthy diet during pregnancy, but it is generally given as a preventative, because there is a gene called MTHFR, methylene tetrahydrofolate reductase, and this gene has genetic variations. The variations in these lead to deficiency in folic acid. So usually, because folic acid from the dietary folic acid is not metabolized and it's not utilized by the body. So in neural tube defects, congenital heart defects, low birth weight, it can also lead to uh, intrauterine growth restriction and miscarriage. So this can also be a cause for miscarriage. Um, we will again be revisiting this gene when we look at vitamin deficiencies in relation to genes. But of course, MTHFR is involved in several body processes. Folic acid is important in several body processes, and therefore, people with the genetic variations are at slightly higher risk, not alarmingly high risk, but somewhat higher risk for cardiovascular disease, cancer, and mental faculties, cognitive faculties. So, continuing with MTHFR, it it also has important implications in terms of preeclampsia, as I said already, miscarriage and stillbirth. And generally, in general population, it can be improved by diet and uh, quite targeted vitamin supplementations. They will need more of the methyl variations of folic acid and vitamin B12, because MTHFR as a side effect can also, the genetic variation more indirectly also leads to vitamin B12 deficiency. So supplementing both of these in the methyl variations, because that is what is impaired in the body. Now, there is another important gene. We will be coming back to this gene again in terms of nutrition, but another important gene that is important both during pregnancy as well as in the breastfeeding period and in early childhood is the gene that is responsible for maintaining balance between the omega-3 and the omega-6 fatty acids. So omega-3 and omega-6 fatty acids are very important, especially in terms of cognitive and brain development. Omega-3 fatty acids are generally anti-inflammatory, and omega-6 fatty acids are pro-inflammatory. So this also maintains the balance in inflammation. Inflammation is not necessarily a bad thing in the body. Inflammation is important to repair areas in the body where there is pathological problems, but chronic inflammation is what is the problem. So when there is an imbalance between the omega-3 and omega-6 fatty acids, then chronic inflammation arises. Chronic inflammation is one of the underlying causes for several diseases such as cardiovascular, diabetes, or most of aging related diseases like Alzheimer's, other cognitive dysfunctions, and all of these. Now, in maintaining the omega fat balance, there are two genes, two related genes, FADS1 and FADS2, that are important. We will be looking at these genes again later. But what happens in especially in breastfeeding mothers and in children dependent on breast milk, is so women with the genetic variation, their breast milk is affected in terms of the omega fat balance. And this leads to reduced immunity in the children. Now, you see that some children, some people, generally from very early childhood, they develop allergy and asthma and other atopic diseases, such as diseases of the skin, allergies of the skin. And one of the causes can be this genetic variation, very easily repaired, right? As you can see, we can take supplements of omega fats, or uh, just dietary intake, non-supplemental, changing the diet with high omega-3 fatty acids. Uh, and these omega fatty acids are very important for cognitive development, so brain development and neurological development, and therefore it impairs IQ um, of the child. And one of the more prevalent diseases, the more new age, so-called new age disease, is ADHD, or attention deficit hyperactivity disorder. It also contributes to that. So it is important both in the breastfeeding, lactating women, as well as in children. Now we have actually covered a lot of different genes, a lot of different conditions that links nutrition and genes and whatever disease that can bring about when there are variations in these genes. So we will be looking at certain conditions. We will, I think, for the rest, we would have whatever we have not covered, we will dwell in more detail. Whatever we have covered, we will go through slightly faster, because as you can see, genes and nutrition play a role in several different aspects. So it's not that one gene or one particular nutrient leads to only one particular disease condition. It has a wide range of impact. Now, genes also have an impact in nutritional diseases as congenital diseases. One example we see here is familial hyperlipidemia, or this is, in this particular case, it's called type 3, when there is a mutation in the gene ApoE. Now, ApoE is also the gene that predisposes one with very high risk for Alzheimer's disease and vascular dementia. So that is a different gene. One variation leads to Alzheimer's disease, whereas there is another variation that leads to hypercholesterolemia, hyperlipidoproteinemia, um, and therefore this is a diagnostic genetic test that can diagnose a person. As I said earlier in the presentation, why do we say why do we say when we have high blood pressure to limit salt intake? And this is not a general rule for everyone. This is only for certain people. There are various genes that contribute to salt sensitivity in hypertension. One of the genes that we have already seen is ADRB2, and this acts again in the RAS system, and this leads to salt sensitivity. We have already covered various aspects of its role in terms of obesity. Now, another gene is called NED4L. NED4L is a gene that generally inhibits sodium reabsorption in kidneys. So it leads to sodium elimination. Now, there is a variation that leads to lower activity, which means decreased inhibition. So higher um, uptake of sodium. Now, this leads to salt sensitivity in hypertension. So we are in this slide, we are just looking at a couple of genes which are widely prevalent in the population. Anywhere from 40 to 50% of the population have these genetic variations, and therefore the general condition that when you have high blood pressure, limit your salt intake. But there are also other genes that play a role in salt sensitivity in hypertension. Um, Thrombophilia is more of a genetic disease. There are a few very important genes which have mutations that lead to thrombophilia, that lead to cardiovascular and cerebrovascular disease. These are not genes that are directly related to nutrition. So even in cases where they're not directly related to nutrition, for instance, a person with this genetic mutation, we know that the person is going to have high risk for heart disease or stroke, which means that all the nutritional, dietary, and lifestyle recommendations that go for heart disease and stroke will be applicable for people with these genetic mutations just because of their high risk. Otherwise, this does not have any direct, these genes do not have a direct role in terms of nutrition. Now, high cholesterol is probably and sadly one of the commonest conditions in the population. Almost, or I think absolutely everyone with high cholesterol is given the class of drugs called statins. There are various different statins. And a minority of the population, anywhere from 18 to 25% of the population, do not tolerate statins at all. So some of them may complain about muscle pain. Many of them may not have muscle pain. Some of them may have high creatine kinase levels in their blood and urine. So these are things that can be tested, but generally what you will find is that a majority of these people who have adverse events linked to statins, they just are not adherent. So one of the most common complaints of doctors is that patients don't stick to their medicines. And patients don't stick to their medicines with very good reason, because they may have a genetic variation. We have seen this bilirubin. It is also the transporter of statins. So in patients with this particular variant, statins are not cleared from blood. So the variant is defective, which means the statin is not transported effectively, and therefore it is not cleared from blood. That means there is higher concentration of statins in blood, leading to these side effects. Now, nutritional deficiencies, we have covered some of these genes, and we will be seeing at a few new genes. And this is an area where I'm going to tell you more about certain risks of, yeah, we'll come to that. We've already seen FADS 1 and FADS 2 and how these are important in omega fatty acids maintaining their balance, and imbalance can lead to unregulated inflammation or chronic inflammation, which is which not which is not dangerous immediately, but over a long period of time leads causes a wide range of disease conditions. So yes, these can be given as supplements, but when you give as supplements, the generally recommended supplement is fish oil and fish sources. Nowadays, in supplements, there are vegetarian options that are coming about because you can have microorganisms synthesize nutrients, and therefore these will be vegetarian options. They can be packaged into vegetarian capsules without gelatin. So all these improvements have come about. So vegetarians can also take vegetarian supplements for omega fats. Now, this genetic variation has actually evolved among Indians because of a very high prevalence of vegetarian lifestyle. So when we have a high prevalence of vegetarian lifestyle, omega-6 fatty acids. Now, what happens? Omega-6 is the pro-inflammatory, so not the very good fatty acid. Now, this bad fatty acid is more prevalent in meat, eggs, all kinds of meats, and a lot of the animal products and animal diet. Now, in case of a vegetarian lifestyle, you still need omega-6 fatty acids. And therefore, this genetic variation, we have evolved this genetic variation that leads to conversion of omega-3 to omega-6 fatty acids. Now, this was all very good until a few years ago, but nowadays, the people's lifestyle and diet have changed a lot, and it's not necessarily non-vegetarian foods anymore, but people consume a lot of junk foods and fast foods, and these junk foods and fast foods also contain high levels of omega-6 fatty acids. Now when you have this genetic variation that is already going to tilt your balance in a different way, combined with diet, that is where it leads to the problem. Otherwise, per se, a healthy vegetarian lifestyle with this genetic variation, it's evolutionarily evolved to bring about balance. Um, Only in case of modern, fast food, junk food kind of diet, this variation is going to play an adverse role in among vegetarians. Among non-vegetarians, this variation will always have an adverse role. We already saw the gene MTHFR. It has two highly prevalent variations. Now, one of these variations is way more important. The first one, C677T, is way more important. The other one is contributes less. Therefore, one you definitely, if you're going for the test. So now we are going to talk about how genetic testing plays a role and how it is important, because you may have come across, many of you may have come across a lot of advertisements or marketing saying that test your genes and eat according to your genes. So that is what today's entire topic is about: precision diet and nutrition. It's not, on the whole, it's not bad at all. It is quite, it may be good, especially for people that are very conscious and aware of it. Um, so in now we are going to look at certain the risks of these marketing. What are people not telling you in their marketing messages? What are the advertisements not telling you? How to pay more attention, how to ask more informative questions to find out, do you want to take that test? Do you want to choose this particular lab to take that test? Are they testing the important gene? Are they testing the important variation in the particular gene? So one of the examples is MTHFR. Usually labs test for one or both of these genetic variations, but as I said, one of these is most important. The first one, C677T. Um, if any lab is going to test only for the other variant, then that is of absolutely no use. Um, so these are areas to pay attention. Now, we did not look at vitamin A deficiency so far. There is a genetic variation called BCMO1, which impairs the utilization of vitamin A in the body in terms of conversion to retinal, and therefore it affects several body processes. Now, vitamin D Until a few years back, people were of the opinion that VDR, the gene VDR, stands for vitamin D receptor, and there are several variations in VDR, and people were all confused that these variations have an impact on vitamin D levels and vitamin D deficiency. And vitamin D deficiency seems to be one of the most popular diagnoses of today's times, that everyone seems to have vitamin D deficiency, and everyone needs to take vitamin D supplementation. Mm, so, of course, I mean, this is also linked to our modern lifestyle where we are not exposed to sunlight at all. So, that is part of it. But when you're exposed to sunlight, then you'll generally not face this deficiency. But there are genetic factors involved. And a lot of the labs still test for vitamin D deficiency in terms of the gene VDR. And today we know, over the last few years, we know for sure VDR does not have uh, any meaningful impact on vitamin D levels in the body, and therefore it is an absolutely useless gene to test in terms of vitamin D levels or deficiency. There are other genes, especially genes involved in transport of vitamin D in blood and the gene involved in its metabolism, um, that are linked to vitamin D deficiency. So when you choose a lab or a genetic test, it's important to pay attention to these smaller details as well, because otherwise people, labs generally market and advertise saying that, oh, we cover 40 parameters, or we cover 200 parameters, but they may be testing for the wrong gene and giving you, certain, some of the results will not be useful. They can be useless results. So, for instance, in vitamin C, uh, a lab may test for vitamin C deficiency, and usually it's because of variations in two genes, SVCT1 and 2, and these are vitamin C transporters. But testing for variations in these two genes is absolutely useless, because the variants are so rare. It is I think 1 in 10,000, or even fewer, that kind of prevalence in the population. It is so rare that you don't need the test. The result is generally meaningless in the sense that almost everyone will get the same result, that you do not have these variations, and therefore you do not have deficiency because of these variations. In case of vitamin E, people have found a few genes have an impact. And by a few genes, I mean a handful of genes. But again, in this case, there is no use testing these genes, because they have also found that cumulatively, taking all of these genes together, the contribution in terms of variation in vitamin E levels is less than 2%. It's so minuscule that there is absolutely no meaningful impact in testing for these genes. And in terms of vitamin K, there is a very popular gene called VCORC1, which can be tested. Now, this I will not say is completely useless. It is a useful gene for not just for vitamin K, but also drugs targeted towards vitamin K. For instance, uh, vitamin K agonist, um, antagonist, I forget. For instance, warfarin. Warfarin or Coumadin is one of the most popular blood thinners that is given, and that directly targets VCORC1. But it's important to test this gene, especially for symptomatic effects. Asymptomatically, you do not need to worry about this particular gene and vitamin K deficiency. Now, deficiency arises also from malabsorption. We have seen in cases like celiac disease, lactose intolerance, um, which genes are involved, and these lead to malabsorption because of maldigestion, and therefore these lead to malnutrition. And in other cases of irritable bowel syndrome, or in generally in all cases of inflammatory bowel disease, like Crohn's disease and ulcerative colitis, there is deficiency, nutritional deficiencies resulting from uh, malabsorption. And Crohn's and ulcerative colitis, being autoimmune diseases, they do have genetic basis. Um, I'm not aware that we have targeted down the genetic mutations in such a way that there are meaningful genetic tests to be offered. There may be tests offered by some labs. Now, let us quickly look at genetics and its effects in general wellness. So, not in terms of disease, but in terms of general wellness. Of course, nutrition plays a very important role in everything from growth, development, allergies, in terms of fitness, fitness in life, or fitness is especially important for sports people, mental fitness, which is important for everyone, but also for people facing mental stress. Um, so in skin and hair, we have seen a few of these genes that are important in skin and hair. One of these that we saw is the omega fats. Omega fats balance is again very important in healthy and glowing skin, for instance. Mm, we have seen genes important in weight loss and gain, for instance, FTO and MC4R, and also ADRB2, which affects fat accumulation and fat burning. So, what are you predisposed to? Are you predisposed to accumulate fat, or are you predisposed to burn fat, or are you against both? And therefore, how to manage these conditions. But again, in case of weight loss and weight gain, there can be impact of RAGE and UGT1A1 as well. Now, this is where I said we are going to be looking at toxin elimination and the gene UGT1A1 again. In today's world, we are exposed to a lot of toxins. We are exposed to toxins in our diet. And this is not just from meat, but even you know that today when you consume fish or meat or anything, you're taking in plastics. You're taking in plastics even when you drink water and Coca-Cola and everything. Uh, when you walk on the street, you're exposed to a lot of pollution that you're breathing in, and these all of these get absorbed. So all these compounds, generally we are looking at two categories of compounds called PCAs, polycyclic amines, and PAH, aromatic hydrocarbons. So these two classes of compounds are quite toxic to the body. And UGT1A1, we saw it in terms of how it helps in the breakdown and elimination of bilirubin. This UGT1A1 also helps in the breakdown and elimination of several different drugs, chemicals, and metabolites, both in the body as well as the pharmaceutical compounds that we consume. Um, and also environmental toxins and food dietary toxins such as PCA and PAH. So a variation in this gene leads to highly decreased activity of the gene, which means toxin accumulation in the body. There is inhibition of the toxin elimination process. And when you accumulate enough toxins, this leads to, disease conditions, but also in extreme cases to gastrointestinal cancer. So people with variations in UGT1A1 generally will be advised not to consume meat at all, or at least to avoid completely pan fried or grilled meats, which the when you grill and fry a lot, it forms the black crust. The black crust is what generally contains PCA and PAH and all that. So you need to avoid those, especially people with the variation in the gene. And we would generally advise people with the genetic variation to increase green leafy vegetables, certain other fruits and vegetables, and garlic in their diet, because there are natural compounds that increase the activity and the efficiency of UGT1A1. So this is an area where you can have natural compounds to overcome the genetic variation. Okay, in terms of muscle or marathon, for instance, sprinters or marathon runners. Now, this is generally in the area of fitness genetics, so we will not be talking a lot about fitness genetics today. Are you more predisposed to run short distances, or do you have enormous stamina to run a marathon? But where we are going to be looking at this is in terms of consumption of protein shakes and muscle building. There, why do some people find it easy to build muscle, and why do some people not build muscle at all? How much ever exercise or gymming that they do, and or how much ever protein shakes that they consume. Now, there are genes that contribute to this, of course. Actin 3 is generally the muscle gene. Some people have this gene, which means that they find it very easy to build muscle. A lot of us, especially in South Asia, lack this gene, and therefore it is more difficult. Usually, you don't. Build muscle. But fortunately, muscle building process is not just linked to one gene. There are other genes involved. We already saw the gene ACE. Now, this is generally also referred to as the marathon gene because the variation that leads to impaired ACE activity, people will run long distances. They generally have high stamina um, and endurance activities. And therefore, these people also do not build bulky muscles. You will naturally see this difference in terms of runners between sprinters and marathon runners. Also, in terms of fitness, we will there are genes that overlap between nutrition and in terms of what kind of exercise and training regimen to undertake. Skin and hair nutrition, we have already seen fat is two. Omega fats, I mentioned that it is important for skin and hair nutrition. Now, the other, we also saw RAGE gene. Now, people with the genetic variation, aging generally is a process where you have advanced glycation end products built up in the body. And there is a very simple test. Dermatologists usually have this UV light or a kind of light that they shine on the skin to find out how much advanced glycation end products have you accumulated. And that is generally a sign of aging, but of course, it's also linked to the genetics of a person. So these are a few genes that are involved, that are important for uh, skin and hair nutrition. And aging in terms of rage, the skin autofluorescence is what I was talking about with the shining of the light. You see the autofluorescence when you have high buildup of advanced glycation end products. And mm, aging related diseases with fat is too, we have seen this. There are other genes that are involved in aging per se, and in aging, normally and naturally, nutrition always plays a role in terms of higher antioxidants and lower um, oxidative stress leading nutrition. So today we have covered a wide variety of topics that combine the areas of nutrition and genetics and their impact in terms of general wellness in various areas, right from sports to beauty to aging, but also more importantly in terms of several disease conditions. And these are variations. What we have seen today, these are conditions that are uh, prevalent among these are genetic variations that are prevalent among the wider population, not necessarily only in people with particular disease conditions. Thank you very much for paying attention, and I will be happy to discuss and answer questions now.
Okay, uh, thank you very much, sir, for very nice and very depth that is info given regarding this gene particularly. So I would like to ask few questions, sir. Hello, can you hear me?
Uh, yes,
Yes.
yes, please go on.
Okay, okay. So I would like to know, sir, some that is which type of diabetes particularly is very common in children.
Which diabetes is common in who?
In common in children.
Sorry, there seems to be
Children.
some disturbance.
Children.
In children. Oh,
Yeah, yeah.
nowadays there are quite a few different kinds of diabetes. So there is maturity onset diabetes of the young, and these are usually diagnosed anywhere during childhood, from childhood to adolescence, and even later on in the youth. Um, there is infantile diabetes, which is always diagnosed in infants. There is so that is not necessarily type 1. There is type 1 diabetes. Type 1 diabetes is usually almost diagnosed very early on um, in childhood.
What
Yeah,
is, sir?
these are
Okay.
the ones that I'm.
Okay. What is life expectancy, particularly type 1 diabetes, sir?
Oh, I think they have normal life expectancy with because they carry nowadays the insulin pouch that is always injected into them, and therefore, just before a meal, they just need to press a button, and insulin gets injected into them, and they can eat. So every time before they eat, uh, they take that, and so see they do face incidents of hypoglycemia or hyperglycemia and fainting and all that. But barring those, generally, I think the disease is very well managed today.
Yes, sir. And regarding the, sir, neuropathy, you already explained that. And particularly in which types of this diabetes it is occur, it's more chances neuropathy.
Um, I do not have a direct answer to that. As
Okay.
far as I am aware, all diabetes, there is vasculopathy and inflammation involved, and therefore in all of these, especially in all of these, there is the risk. But it is in terms of how well the condition and the disease is managed also. So for people that are managing the disease very well, some of them are they are genetically predisposed to neuropathy, to developing any of the microvascular conditions, not just neuropathy. But some of them that manage the disease well, where the disease is controlled, some of them may not develop it also.
Okay. So as we Indians, sir, it is very difficult to manage gluten-free diets because we eat a lot of chapatis. We know that in Delhi or that is like. So how we can manage this?
Gluten-free diet, I know,
Yeah.
especially North Indian diet is going to be way more difficult for someone with celiac disease. It is going to be a challenge for someone with celiac disease. Um, I'm not aware of gluten-free chapatis yet,
Yeah.
but I think for people that are determined, I'm very sure, there Italians eat a lot of pasta, right? And there is gluten-free pasta, and pasta is also made from wheat. So you can find gluten-free wheat. So it is just wheat that is processed, or wheat flour that is processed to remove gluten. So after removing gluten, you uh, use that flour. You don't need to, stop chapati altogether.
Yeah. So more needs now more needs
Sorry.
that is to particular. Hello. So
Yeah.
nutraceuticals in that we can that is by incorporation of this gluten-free diet. Nutraceuticals particularly, can we talk about the nutraceuticals?
In
So
terms
can
of
it is
celiac disease,
huh,
see, once you have the disease under control, which
okay.
means if you are completely avoiding all gluten-based food products, then you will not face any symptoms at all. And over time, your intestines will return back to normal and you will not have malabsorption.
आप
But
यहाँ कब ज्वाइन
when
किए थे
you're
सत्येंद्र जी?
when you're facing the
सिलेंडर
symptoms,
ना हुआ ना
of
आपका?
course, you need
अच्छा बात हो गई है, ओके
supplementation
सत्येंद्र
in
को
terms of iron,
सत्येंद्र सर को तो अब उसमें लगाया ना, कल की सर का
nutritionists
मैम
and
में,
Dear
dietitians or the
हाँ
participant, please mute yourself.
gastroenterologists may also advise general vitamins and minerals.
Okay, so
हाँ
one more thing, sir, that is regarding you a lot of that is talk regarding this PCAs and pH. So it is
Hmm.
very difficult to that is avoid also because we don't know exactly when we that is go to the particularly restaurant and all that things. You know that nowadays there is a lot of available at tandoor. Okay, on that particularly such type of that is maybe probable occurs.
Yes.
Yes, so it should be avoided. No? That is whatever you that is explain in that. It is a very high risk.
Uh,
Okay, but
See, yes, in general terms, I mean,
uh,
when you walk on the street, you're exposed to so much
yeah,
pollution, and when you eat, even when you eat just vegetables, vegetables contain today's a lot of the fertilizers and pesticides, which are harmful to your body. But when we come to the PCA and PAH alone, they are in higher concentration on the black crust that is formed,
yeah.
especially as you said, as you pointed out. I am generally not aware of the tandoor and all very much.
Okay,
So,
okay.
yeah, but yes, as you pointed out, in tandoor cooked food, that you
Yeah,
will find that more, right?
yes,
Um,
yes, yes.
See, the body naturally fights and removes these toxins. So toxin elimination is a natural body process, and that is the gene that is involved is UGT1A1. Now, the variation leads to much lower activity of UGT1A1, and it is in these people that face a problem in toxin elimination. So yes, generally it is good to avoid foods that have these toxins, but especially for people with the genetic variation, it is very important to avoid those particular kinds of foods.
And sir, one more thing that is, it is a very common question, and we are so confused regarding the when we are diabetic. Okay, at that time doctors that is say that you take meal after 2 to 3 hours, or exactly during the days at least 4 times. So is it recommended?
Um, I do not know at all. Uh, yeah, I do not know about that. One of the points I actually wanted to discuss when we were talking about personalized medicine and precision medicine in the very beginning in the introduction is that, see, Western medicine is a case where you have, okay, one drug that is given to everyone with a particular condition. But in Ayurveda, that is, it was never seen like that. I mean, in originally itself, you categorize people into three different conditions, three different categories. Everyone was immediately categorized into three different categories, and then there are several qualities and categories that they can be subcategorized into. So Ayurveda and probably other traditional systems already follow a more personalized medicine approach
Yes.
without the awareness of genetics. Now, how to link genetics and these traditional and holistic medicines is an area of research that, as far as I know, it has not been undertaken. To answer your question, see, your question, I do not know the answer to that particular question, but generally what I see is that, especially in the West, they come with one size fits all approach that everyone should sleep for 8 hours. The recommended daily allowance for every particular nutrient is fixed for all for absolutely the entire population, this is the amount of calories that you need, and this is the amount of each particular nutrient that you need every day. So, and that's not the way our body functions. I mean, our body functions depends on the variety of activities that we are exposed to, the different climates that we live in, the different diets that we follow. So all of these have a huge impact also. So I don't generally, I don't listen to one size fits all kind of approaches.
So it is a better way to adapt. That is Ayurvedic, as suggests. That is a daily consumption. That is 2 times meals. That is okay for us.
Yes, I generally eat only 2 times
Okay.
meals. Yeah.
And one more last question, sir, regarding this UGT1A1. That is, you explain that. So what is
Mhm.
exactly importance of that UGT1A1?
So that is the gene that is responsible for the breakdown of a lot of chemicals, including pharmaceutical compounds, endogenous chemicals like bilirubin, and also the PCA, PAH, and everything. So it is the gene that functions in the body in terms of breakdown of these chemicals and therefore their metabolism and elimination from the body. So generally, in terms of genes or anything that you consume, you can, especially being from pharmacy background, all of you are aware of
Yeah.
pharmacokinetics and pharmacodynamics. Now, all this pharmacokinetics and pharmacodynamics, all of these happen in our body, occur in our body because of genes. So the genes regulate and play a direct role in pharmacokinetics and pharmacodynamics. So, for instance, certain pharmaceutical compounds we take in the form of prodrug, and there is a gene that is responsible for breaking down the prodrug into the active drug. And now the active drug plays an effect on another gene, which is the target. Now, once it has played its effect, then there are genes that are involved in transporting the drug, and there are genes that are involved in metabolizing to in the process of elimination of the drug from the body. So all of these different processes, there are genes that are involved and play a role. And therefore, wherever there are genes, there are genetic variations involved. And therefore, in people with certain genetic variations, they will have to take certain precautions.
Okay, sir. So very, really, very nice and very impressive lecture, sir. Please.
Thank you very much.
Any other questions, participant?
Hello.
Hello, sir.
Hello. Hello. Good morning, sir.
Hello, sir.
Hello.
Good morning, sir.
Yeah.
I have a couple of questions. My first question is ideal diet which we can describe to pregnant women regarding this nutritional.
One ideal diet for all pregnant women. Uh, I do not know. Maybe there is such a thing. I'm not aware. But yeah, did I understand your question correctly?
Yes, sir.
You are looking for one ideal diet for all pregnant women.
Yes.
Yeah, I honestly do not know, because I mean, when you speak of chapati and tandoor itself, um, tandoori food, I mean, we
Ah,
don't eat that a lot here, right? I'm talking from Madras. So
okay.
chapati we do eat once or twice a week, and tandoori food a lot less. So we eat different things in different places. So I'm not aware of one diet.
Okay, sir. No problem. Thank you, sir.
Hello. Good morning, sir.
Hi, yes.
Sir, myself Tirupati Rasala. There is one question of mine. Sir, as we know that most of the people's they're having a genetic disorders, and we are discussing about the nutrigenomics. So, would this will be beneficial in order to treat those genetic disorders?
Okay, as I said in the very beginning of the talk today, we did not see genetic disorders per se. I mean, you can call gluten sensitivity or celiac disease conditions like those as genetic disorder or genetic disease, but we did not look at genetic disorders per se in terms of congenital nutrient deficiency and all those. Now, congenital nutrient deficiencies can have either genetic impact or non-genetic fetal developmental impact. So there can be both genetic and non-genetic reasons. We have not seen those today at all. And yes, nutrient supplementation is essential in people with genetic disorders leading to nutrient deficiency.
If you know the cause, that it might be because of the diet deficiency or the particular the content, right? So if the people suffering from the particular diet deficiency, that gene expressions is completely changed. So by means of taking those genes, can we treat those kind of genetic disorders?
By taking the nutrient.
Yeah, because it is nutrigenomics. It is completely acting on the gene and gene expression. So that means it having ability to change some kind of some sort of the gene expression. So by means of changing the gene expression, there might be several disease or disorders. So when we know the cause and we know the particular gene that is responsible, and by means and we also know that the particular diet and the particular diet content that is responsible for expressing this kind of gene. So can we take that kind of diet which will again it will restore the expression of the gene? Can we do that? So is there any kind of research that is going on particular this field?
Yes and no. One is absolutely everything that you consume, breathe, or even when you don't breathe or don't consume anything, their genes are always playing a role in every body process in your body. So, in terms of you want to uh, take particular dietary or nutritional stuff in order to change your genetic expression, correct?
Right.
So, for instance, there are almost everything that we consume. For instance, everything that we consider good for like flavonoids or any antioxidants or vitamin E, for instance, as an antioxidant. So these will have an impact not just at the protein level, but also at the genetic level in terms of the antioxidant pathway and the anti-inflammatory pathways. So, and this is also an area where I was saying at a couple of slides, for instance, UGT1A1, where we have seen quite a bit of discussion now. People with just one so as I said, there are two copies of genes, and people with just one variant where the other one is completely normal, you can explore. There are drugs that activate genes. So similarly, you can look at what are the natural compounds and nutrients that can activate that particular gene, and therefore, generally, the approach would be to go the natural route instead of taking drugs. Only in some cases you would where you absolutely need drugs or you find it more convenient because yeah, of course it is more convenient. um, so yes, as do we have a lot of research in this area? Unfortunately not. We have a lot more research in this area in terms of how curcumin, the the active compound in turmeric, how curcumin has an effect on genes and all of those. That has been quite well researched. So similarly, certain very particular compounds, but how turmeric has an impact on genes, that is quite less researched. And I think it is always better to eat turmeric than to eat curcumin.
Okay, thank you, sir. I think so the field of nutrigenomics is not completely explored, and it under the field is now exploring right now. Am I right, sir? Because a lot of
Correct.
research need yet to be, a lot of research need yet to be done, and we know the particular genes and the proteins and the molecules at the molecular level, and we are studying the basic molecular level, how the gene is going to be expressed at what situations, what conditions the gene is expressing. So we are studying the basic research right now, so that accordingly we can manipulate the nutraceuticals, so by means of which we can treat several kind of genetic disease or disorders in maybe the latter stage after 15 or 20 years. Might be possible.
We still do not know how many, the exact number of genes in the human body. So there is a lot still to be seen. And in even diseases like diabetes, for instance, which we know has a huge genetic um, basis, we there are just so many genes involved, and the weightage of each gene and the weightage of each variation or mutation in leading to diabetes, and the interplay among all of these, it's just so complicated that uh, yeah, arriving at very very well defined answers to a lot of these questions, it's still quite some way off.
Yeah. So I think so there are around 30,000 genes in a human beings of these 23 pairs of chromosomes. As far as concern, as per my knowledge, around 30,000 genes. And so out of which around 2,500 or 2,900 something genes were explored, and it was studied and it was researched, and remaining yet to be studied as per the HGP Human Genome Project.
Yeah, but depending on who you ask, people will say anywhere between 20,000 to 30,000, the number of genes. So we still don't know what is the exact number of genes. And there are other parts of the genome called pseudogenes. There are various other regulatory aspects. And how are these regulatory aspects turned on, turned off? How are genes switched on, switched off? There is a lot more that we don't know than what we know so far.
Okay, fine, sir. Thank you. Thank you, sir. Thank you very much.
Thank you so much, sir. Now I would like to request Ms. Jidnasa ma'am to the session.
Thank you, Anagha. I would like to thank Dr. Sooraj Ratnakumar sir for such an informative session. During the session, sir explained importance and benefits of precision diet and personalized medicine. Sir highlighted effect of genetic variation on obesity, diabetes, osteoporosis, celiac disease, irritable bowel syndrome, pregnancy, etc. Also, sir focused on effect of genetic variation on vitamin deficiency. The session concluded with discussion on the use of genetic testing and precision diet for toxin elimination, growth and development, fitness, skin and hair nutrition, etc. On behalf of Bharati Vidyapit College of Pharmacy, Kolhapur, I express my sincere thanks to you, sir, for sharing your valuable experiences with us. This was really an amazing experience for all of us. Thank you once again, sir.
Thank you very
Thank you
much
so
for
much,
a
ma'am.
very lively discussion as well.
Yeah, thank you so much, sir. I, Miss Anaga, on behalf of Bharati Vidyapit College of Pharmacy, Kolhapur, take this opportunity to thank our eminent speaker for his wonderful presentation and valuable time. Thank you so much, sir. Now I request all the participants to turn on your camera so that we can have a photo with our eminent speaker.
Good morning, ma'am. Actually, my camera is not working, so I'm unable to open it, ma'am.
It's okay, ma'am, no problem. Thank you all. Dear participants, now we will have 5 minutes break.
Thank you, Sooraj sir.
Thank you very much, sir. Dr. Sooraj. Very nice session. Okay.